Now we will proceed to our next session on miscellaneous. Our respected chairpersons are Dr. Sanjay Basu, Dr. Gautam Chattopadhyay, Dr. Suvro Ganguly, and Dr. Saunak Paul. Now we will hand over our session to our respected chairpersons.
Good morning. We are going to start this session. The first topic is Interventional Radiology Approach for Chiari Syndrome. And the speaker is Dr. Mausum Dey. May I request Dr. Mausum Dey to come to the dais, please.
Good morning, everyone. So, thank you, the organizing chairpersons and all the seniors and colleagues of mine. So, today's topic is Chiari syndrome, how we approach. So, as we all know, the Chiari is nothing but a hepatic vein outflow tract obstruction, the HVOTO we commonly call it. So, we will go through some of the cases and how do we approach in those cases. So, let's start with the CT scan of this patient. This is a 35-year-old gentleman who presented with refractory ascites. Ultrasound showed coarse ecotexture of the liver and obviously the diagnosis of Chiari. Then the patient underwent CT portovenogram. So, here is the CT scan of this patient. You can just focus on the IVC. Here the IVC is in the intrahepatic portion extremely narrowed. Inferior to it in the suprarenal segment, it's almost of normal caliber. So, this is the coronal reconstruction. You can see the suprahepatic and the infrahepatic portion of the IVC looks fairly normal. In the intrahepatic segment, it's very thinned out. Now we did an angiogram. Sorry, this is a CT again. This is the angiogram. So, here also you can see the same finding as we have obtained in the CT scan. So, what should be our approach? First of all, is it pathological or not? This is a case of Chiari syndrome. We know hepatic vein outflow obstructed, USG showed it, CT also confirmed it. Now, this is the angiography finding. But this IVC is absolutely perfect IVC. So, this is a misconception that whenever there is an IVC narrowing, everybody goes in and stent it. No, this IVC is absolutely 100% perfect IVC. This is just an extraluminal impression of the caudate lobe, because whenever there is a patient has a Chiari syndrome, caudate lobe is hugely enlarged, it will compress on the IVC. Just look at the CT scan. Here there is no collateral around the IVC. Had it been such a significant narrowing, there must be some collaterals. Both in the CT and in the angio, we didn't get any collateral. So, this IVC is absolutely normal. We didn't do anything in the IVC. Then look at the hepatic vein. This is entirely obstructed segment. So, this patient has a Chiari syndrome with hepatic vein distal segment obstruction. IVC is just showing narrowing due to extrinsic compression by the caudate lobe and doesn't need any treatment at all, not even the angioplasty, stenting possibly nahi hai. So, we did a balloon angioplasty. You can see the balloon is gradually inflating. There is a narrowing in the mid segment of the balloon. Gradually we knock off the waist of the balloon and finally achieve the good dilatation. This is the post angioplasty run. Stenting we recommend for hepatic venous distal segment because that segment is very resistant to angioplasty. So, we prophylactically do stenting in hepatic vein. But every time from this case, my message is try to avoid IVC stenting whenever possible. And first of all, diagnose whether IVC doesn't need any treatment at all. That is the question. Because the last case, the classic example you can appreciate, CT showed a narrowing of the IVC. But that is a expected finding in Chiari. It doesn't need anything. Coming to the next group of things, most commonly in Chiari, we try to recanalize the right or middle hepatic vein. But in certain situations when those veins cannot be cannulated, you can recanalize the left hepatic vein also. Here is the left hepatic venogram. You can see the obstruction and then the balloon is gradually inflated and we knocked off the obstruction. Okay. Coming to, as you know, Chiari is a state of dyscoagulation. It's an unpredictable hypercoagulable state. So, here you can see we have done right hepatic vein canalization. We did a ballooning, and after ballooning, This is the angiogram. Even just after placing the stent, there is formation of thrombus inside the stent because you do not appreciate wall-to-wall flow. So thrombus already had started building into it. So these are the hard cases where you have to very difficult to manage because you have done the hardware portion, but now the coagulation will give you pain. So I'll come to these things later. Coming to another atypical cases of Chiari syndrome. This patient had a hydatid cyst. He was taking medications for it, but didn't undergo any form of surgical or minimally invasive therapy. Now, this patient presented with refractory bleed. You can see there is a large hydatid cyst with wall calcification. It's a dead cyst. And the liver is very much coarse. It's a cirrhotic looking liver. Now, obviously, in a cirrhotic background, surgery is always, a surgeon doesn't want a cirrhotic liver every time in hydatid. So, this is the angiography. You can see, I am repeating the angiogram again for you. With IVC, here you can appreciate the azygous and hemiazygous systems. So there is collateral in IVC. This IVC needs treatment. Now we cannot see good amount of hepatic vein also. Now how to approach this case? Obviously he is not a very good candidate for surgery because of his liver condition. So what we did, this is the hepatic venogram. You can see this entire thing is a collateral. The original hepatic vein is not seen. Entire thing is a collateral, but it's a big collateral. It's draining well. If we can recanalize the IVC, this patient might do well. So what we did a stenting of the IVC. Here in this case, ballooning will not work because the hydatid cyst is already there, calcified and dead. We cannot remove the hydatid. So if we balloon it, it will open up, and even just after taking out the balloon, it will collapse again. So ballooning doesn't have any role. So in these situations, which is a very rare, you can understand hydatid and Chiari combination, in these atypical cases only, IVC stenting in first setting is recommended. Otherwise, message is very clear. Always try to prevent IVC stenting whenever possible. Now, just to emphasize my statement, this is a 27-year-old male patient. He's a radiology technician by profession. He was a diagnosed case of Chiari syndrome in some other institute. He underwent a IVC stenting. Now already the patient had a stent in his IVC. So we tried to cannulate it. The hepatic vein is not at all seen. So what we have to do here? We have to do a TIPS because the patient is having refractory bleed. So we have to do a TIPS. Now the IVC is stented. How will he puncture the liver from the medial aspect and enter into the portal vein? This is one of the nightmares. You can see this is the attempt. And we have tried a long time. We are fighting with how to break the stent. We have to break the struts of the stent. You can see my metallic needle is getting bent. So after a long struggle, finally we managed to enter into liver parenchyma. So here we have inflated the balloon. We have broken the struts of the stent. Then we created some space through which we can enter into the liver parenchyma. And then we did a portovenogram. You can see the significant amount of collaterals, which is the cause of bleeding in this patient. Then we did a TIPS through the IVC stent. And even after TIPS, you can see lots of collaterals are here, lots of perigastric and esophageal. So we have to do, because pressure gradient didn't come down well, we have to do some injection of glue into these things to obliterate the varix. Now just look at the pre-TIPS endoscopy. This is the pre-TIPS endoscopy. Usually our gastroenterologists are very fast in doing endoscopy. They don't go that much slow, but this patient has a very weird looking esophagus. That's why he is going very slowly, because he doesn't want to touch the multiple esophageal varices and let it bleed. Anyhow, so there are lots of esophageal varices, post-EVL ulcers, and this is just after 2 months, post-TIPS 2 months endoscopy. Look at the changes. So the message is very clear. This patient, we underwent lots of struggle just because of the IVC stent. Otherwise, we do TIPS in 45 minutes. This patient took almost 3 hours. And lots of struggle, lots of hardware, extra cost were incurred just because of an IVC stent. So that's why always try to maintain our access. IVC should not be wasted with a stent. Okay. This is another case, which is possibly one of the weird case of Chiari I have ever seen in my life. So this patient, you can see, this is a classic IVC obstruction. In lower segment, you can see the infrarenal IVC is normal. Above that, there is no IVC. Entire thing is replaced with multiple collaterals, both azygous and hemiazygous. we tried to cannulate the IVC from femoral axis, then we take a jugular axis, then the two people came in, they tried simultaneously from both axes, and luckily after a long struggle, we were able to recanalize the IVC. We did the ballooning. After ballooning, this is the angio. If I don't write it's a post-angioplasty, nobody would believe that it's after angioplasty. There is no change at all. So this is the situation where you need a stent. Even after angioplasty, pressure gradient didn't come down. The angio doesn't have any improvement at all. So we did a stenting. Rather, it's a long segment occlusion, so we have to use 2 stents. After stenting, the hepatic vein is also diseased. So in the same sitting, we did a percutaneous approach. We did a hepatic venogram. We recanalized the hepatic vein through the side of the IVC stent, ballooned. We placed a stent. But we were unlucky on that day. So due to some inadvertent pull of hardware, the stent migrated into IVC and it displaced from its expected position. You can see here the hepatic vein angio, the stent is crumpled and it moved towards IVC and almost little migrated towards the right atrium also. So we thought let's place another stent through it and end the procedure. Everyone was tired at that time after a long struggle. So we tried that. We tried to restent it. We did that restenting and you can expect there is a stent in hepatic vein and there is a cross narrowing out there. So whenever there is a narrowing in the stent, we have to do post-stent ballooning just like coronary angioplasty. We did that intra-stent balloon, but the balloon got stuck with the strut of the stent. It was a very bad day, possibly for all of us. And whenever we tried to pull the balloon, the entire thing started coming into right atrium, into the heart. So finally, we pulled the entire stent complex into superior vena cava here and placed a fresh stent in hepatic vein properly. And you can see this is the last run. So we successfully managed it. So this is the post-procedure CT scan of this patient. You can see there are 2 IVC stents, 1 hepatic vein stent and 2 misplaced stents, which we have ultimately pulled into SVC. So from all these cases of Chiari syndrome, the message is very simple. IVC should be preserved for future interventions, and whenever we are treating some IVC occlusion, we must be 100% sure if there is any hepatic venous pathology or not, because Chiari has different presentation in different geographic area. In India, Indian subcontinent, 97% of the Chiari syndrome cases have associated hepatic venous pathology. Whether they have IVC involvement or not, that is secondary. Very, very few cases are there with isolated IVC involvement, like IVC waves and all. But most of the patients have hepatic venous involvement, and we should not ignore that. And secondly, regarding anticoagulation, initially our protocol was to start with warfarin and heparin, and after a few days we stopped the heparin and put the patient on warfarin and maintain INR between 2 to 3. But nowadays, many of the gastroenterologists think that with warfarin, and when the patient have a cirrhotic background, INR is a very important marker for them to assess the chronic liver function. And with warfarin, we are probably losing that marker. That's a very easily available marker. So they always advise not to use warfarin and put the patient on subcutaneous heparin like Clexans or the novel oral anticoagulants. This is a newer trend, but initially the conventional treatment was heparin with warfarin cover, and after that continue with warfarin dose modification to maintain the INR between 2 to 3. So I thank you all for your patient hearing. Thanks.
Dr. Mausum, this was a very informative presentation, and is it okay for the organizers if we take a few questions? So Dr. Mausum, when would you suggest the clinicians in their OP to counsel the patient for a hepatic venous stenting or a plasty and a TIPS? Because sitting in the OP, the pricing of both, I believe, will vary by differential of 2 lakhs. So how would they take up the cases, and how would be the counseling done to streamline the referral so that the patients are guided appropriately?
Yes. Okay. The first thing is that always we try to restore the physiology whenever possible. The bookish statement is if the segment of occluded hepatic vein is more than 5 centimeter, possibly recanalization is not possible. Usually people not attempt that, but the practical approach is that every time we try to recanalize hepatic vein to maintain the physiology, And if every attempt goes into vein, then only we go for tips, because tips always carries a risk of encephalopathy, more cost, and it's a non-physiological thing. So tips is a bailout procedure. The basic concept is to recanalize the physiology.
Dr. Mausum,
Sir.
sir, you have any questions?
No, sir.
Any questions from the audience?
Sir, please.
Yes, Mr. Nandi, sir.
Many years ago, we published a series in the Lancet on the scientific about chiari syndrome. And we did the three kinds, obviously, as you know. IVC obstruction, hepatic vein obstruction, and both. And for IVC obstruction, we showed that you can put a stent in, cover stent. For hepatic vein obstruction, we used to do a lateral portable shunt, side-to-side portable shunt.
Okay, sir.
And, side-to-side portable shunt. But the problem is that a lot of these people have thrombosis. And the long term of, I think, your shunt will be thrombosis. Very common in chiari syndrome, isn't it?
Sir, that's true.
Even the big grafts we used to put in, background grafts or PTFE grafts, they used to be thrombosed in 2 years.
That's true.
What's your blockage?
Sir, in IVC, we used to place an uncovered stent. Even in hepatic vein, the routine practice is to place an uncovered stent, not a graft. But in case of tips, obviously we have to place a graft in the parenchymal segment to cover the parenchymal tract, and an uncovered segment in the portal vein, so that the flow maintains into both right and left branch of portal vein. But in case of Budd-Chiari, as you have correctly pointed out, chance of stent thrombosis is very high, because whenever we do tips for other indication, refractory ascites or variceal bleeding, we never give any anticoagulation or any form of blood thinners.
Long-term anticoagulation.
Sir, in non-Budd-Chiari cases, we don't give. But in Budd-Chiari, we prophylactically give them either warfarin or novel oral anticoagulant. But despite having all these efforts, many patients, sir, we have a very short sample size. I cannot conclude anything from that. But in our small experience, many, near about 50% of our patients come up after 1 or 2 years. Some people even within 1 year with a stent thrombosis. That's a very common problem, sir.
We used to do 2 year anticoagulation.
So many patients come before 2 years also, sir.
Thank you very much.
Thank you, sir. Thank you.
It was an interesting session. Yeah.